Good afternoon, and welcome to today's IAC webinar, Introduction to Vascular Interventional Accreditation. My name is Kelly Baer, and I am the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we will monitor questions throughout the presentation and try to answer as many as possible during the Q&A period. On the left sidebar, please note the Polling tab. Today's webinar will feature 4 live poll questions for our audience. Also on the left sidebar is the Resources tab. Click on this tab for a link to today's handout, a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during this webinar, click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the SVU CME credit, you must be registered, logged into this webinar, then complete the survey. The link to the survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. This presentation is intended to provide facilities with an understanding of the application process for vascular interventional accreditation. And with that said, I will now turn this webinar over to today's speaker, Laura Humphries, IAC Director of Accreditation for Vascular Interventional. Laura?
Thanks, Kelly, and thanks for everyone for attending the webinar today to get a little bit of information about our new program, Vascular Interventional. It's new to me as well, so please bear with me as we kind of get through the points here. If you're familiar with the IAC, you probably will see a lot of similarities, but you also see a little bit of differences. So for today, the objectives are to provide a brief history of IAC accreditation for those of you who are not very familiar with the IAC, to review the application requirements for vascular interventional accreditation, to discuss the application process, and to recognize the importance of a quality improvement program. Brief history of the IAC accreditation. So as you know, IAC stands for Intersocietal Accreditation Commission. Our mission is improving healthcare through accreditation. The IAC is a nonprofit professional organization, 501c6. We have over 30 years of accreditation experience. Our board of directors are specialists in various medical fields. We have over 14,000 accredited sites. We are recognized by CMS as an accrediting organization for ADI, Advanced Diagnostic Imaging, and we have 41 medical societies that send representation to the various board of directors. The IAC began in 1990 with vascular testing. They are the founders of the IAC per se. We moved on to create programs for MRI, CT, nuclear, echo, dental CT. In 2013, we began the Vein Center program. Since then, we've also introduced cardiac cath, cardiac electrophysiology, device clinics, and this year last year, we announced the launch of our IAC Vascular Interventional Division, which includes deep venous, peripheral arterial, and hemodialysis access. So vascular interventional, how did we get here? So we started with Vein Center. The Vein Center accreditation has been around since 2012. Since then, we've seen a need to move into a more interventional space. So what we've done here is we've created a IAC Vascular Interventional program. Now, this will include the existing Vein Center, but it will also include deep venous accreditation, peripheral arterial, and hemodialysis access. So for those of you who are Vein Center accredited, you may see things change on your end as far as the website, the portal, documentation. It may say Vascular Interventional. So certainly be aware of that. That doesn't mean that you're in anything different. You are just accredited in IAC Vascular Interventional, but only in the Vein Center space. If you wish to apply in the other procedure areas, you would have to apply in those as well. It's kind of similar if anybody is familiar with the vascular testing accreditation. For vascular testing, you can apply in carotid venous arterial. Well, now it's kind of the same model. You apply for vascular interventional, and you can apply in Vein Center, deep vein, peripheral arterial, or hemodialysis access. Of course, you can do one, you can do two, you can do none, you can do four, you can do as many as you want. You're certainly not required to submit for all of those procedure areas. Now, just to make things clear, for all intents and purposes, this webinar today is to focus only on the new procedure areas of vascular interventional for deep vein, peripheral arterial, and hemodialysis access. We will not be focusing on Vein Center today. So why did we do a vascular interventional program? Well, I have a wonderful quote here by our president, Tom Rook. He says, Vein centers have embraced the ability to demonstrate their commitment to quality through our superficial Vein Center program since 2013, making the decision to offer vascular interventional accreditation an easy one. It's no small accomplishment to demonstrate that your practice meets the kind of current multidisciplinary national standards established by the IAC for vascular interventions. Providers want to know if they're doing appropriate, high-quality work. And if they are, they want everyone else to know it. A little bit about IAC for those who are not familiar. We are a multi-societal approach. We have board members from all different societies that sends representation to our board of directors. This is just a sample of the types of organizations that have committed to sponsoring us as sponsoring organizations across all the divisions. Where do we come up with this stuff? Where do the standards come from? People always I'm calling the IAC. I don't know, where they come up with this. Why are they making these changes, or why does the standard say this? Well, we don't make this stuff up. We do have very specialized people that represent the IAC by creating all of these standards. So it's not us that's doing this. We are supported by, wonderful group of medical professionals that help us write these standards. Specifically for vascular interventional, like I said before, our president is Tom Rook. Our president-elect is Mark Meisner. The immediate past president is Neil Kilnani. Our officer at large is Deepak Nair, and our secretary is Kathleen Osvath. In addition to the executive committee, we also have other board members. They're listed here on the slide. You might be familiar with them. We have Ken Wynn, Carl Fastabend, Fedor Laurie, Ken Rosenfield, Joanne Lohr, Colleen Moore, Catherine Hayes, Arjun Jairaj, Sarah Schansberg, Dominic Zambuto, Derek Middleider, Gilly Munavali, Margaret Mann, and Andre Espinosa. So we have a multidisciplinary approach to this. We have vascular surgeons, we have sonographers, we have advanced practice providers, we have dermatologists, we have interventional radiologists. So we do have a lot of support here on our board. So just to get things started off, just to see where we are here, I just would do a little poll question here. If you could just mark here and let us know, are you currently accredited in Vein Center with the IAC? And do we have the results of the poll? I don't see them here in my panel. Sorry about this. Hold on for just a minute. Okay, unfortunately, I apologize, but I'm unable to see these, so I'm just going to move on for now, and hopefully, oh, wait a minute, now we have it. 76 attendees have said, no, you're not accredited in Vein Center, and 23 say yes. So I'm glad to hear that. We certainly have some new people here, and we do have some great information for those that are currently accredited in Vein Center. Then you may have, you may know a little bit about this, but again, we're focusing on Vascular Interventional, the new programs. So a little bit about the application requirements. What you want to familiarize yourself with first are the IAC Accreditation Standards. And we have different standards for the different programs. It's not just one set of standards. Now, they are very similar, especially the newer ones, the deep vein hemodialysis and peripheral arterial. But of course, since they are very specialized procedure types, there are a little bit of differences. So you certainly want to familiarize yourself with these standards before you start the accreditation process. The procedures for deep venous include venography, IVUS, venous angioplasty and stenting, treatment of pelvic vein reflux, IVC filter placement, IVC filter retrieval and repositioning, invasive treatment of DVT, and treatment of venous malformation. The peripheral arterial procedures include angiography, IVUS, angioplasty, stent placement, atherectomy, thrombectomy, thrombolysis, embolization therapy, EVAR, and cerebrovascular therapy. For hemodialysis access, we have dialysis access angiography and or IVUS, endovenous AV access creation and insertion, angioplasty, stent and stent graft placement, treatment of dialysis access thrombosis, embolization and injection therapy, catheter placement or revision, and dialysis access catheter removal. A little bit about the staff. All staff in the application must meet the qualifying pathways for credentialing, volumes, ACLS, and CME requirements. These include the medical director, medical staff, medical physicist, interventional technical staff, APPs, and nursing staff. The medical director and medical staff, they must be board certified in general surgery, interventional cardiology, interventional radiology, vascular surgery, be an ABVM endovascular exam diplomat, or for hemodialysis access, you can also be board certified in nephrology. The case volumes, those are always very important when applying for these accreditation procedures. For deep venous, when we're talking about the medical director and medical staff. So these volumes are volumes over the previous 3 years. So you might ask, okay, well, we don't do all of these things. And that's quite all right. You certainly don't have to perform all types of these procedures in order to apply for accreditation. However, if you'll notice in the next few slides, I do have stars next to the procedures that you do absolutely have to meet the volume pathways for. So for deep venous, you must perform venography, 20 cases over the previous 3 years, and IVUS of 20 cases over the previous 3 years. If you wish to perform or apply for any of the other types of procedures under deep venous, they all require 15 cases over the previous 3 years. But again, you do not have to apply for all of them. You only have to apply for the venography and the IVUS. Peripheral arterial, we have our little stars here for angiography. So that's your winner there. In order to apply for peripheral arterial, your medical director and staff must have performed at least 40 cases over the previous 3 years, each staff member, not combined. That might be a little bit confusing. If you're the medical director, you must have 40 cases. Any additional medical staff must have 40 cases also. If you perform any of these other types of peripheral arterial procedures here, you will see the case volume can range anywhere from 10 to 30 cases, depending on what type of procedure it is. And again, these are over the previous 3 years. For hemodialysis access, this is a little bit different. We don't have our starred programs for our procedure types per se. For hemodialysis, you just have to have performed at least 60 cases over the previous 3 years. So these cases can be it can be a total of any of the types of procedures listed below. There are no minimum requirements for each type of procedure. So as long as you meet your 60 case volumes in any of these or a combination of these, then you are eligible to apply. If you have provisional medical staff. So if you have medical staff that don't meet these volume requirements, the medical director may appoint a qualified medical staff member as provisional who meets all the criteria except the volumes. The provisional medical staff must perform a minimum of 5 cases under direct supervision by a qualified medical staff member. The medical director is responsible for reviewing the case logs, and these case logs must include outcomes. And the provisional medical staff must obtain full medical staff status prior to reaccreditation. So you can only be provisional staff member for 3 years. You can't ride the provisional staff gravy train more than one accreditation cycle. For CME, for the medical director and staff, you must obtain a minimum of 30 Category 1 CME credit hours related to the procedure area. Whether it be deep vein, arterial, or hemodialysis. You must have at least 2 hours of these 30, must be fluoroscopy radiation safety training. Interventional staff. All interventional staff must be registered radiologic tech for the American Registry of Radiologic Technologists or the Canadian Association of Medical Radiation Technologists. That's a mouthful. And you see the credentials down there, ARRT, RTR, CAMRT, ARRT, CV, ARRT, CI. Interventional staff must have a current BLS, and they must obtain a minimum of 15 hours of Category 1 AMA or RCEM approved CE in the past 3 years. And similar to the medical staff, 2 of those CME hours must be relevant to fluoroscopy radiation safety. APPs are defined as a physician assistant, PA, or nurse practitioner, NP. APPs must have current BLS or ACLS. ACLS is required if your facility is using moderate IV sedation. The APP must perform under the direct supervision of a physician the evaluation of a minimum of 50 patients in the previous 3 years in whichever procedure area you're applying. And they must obtain a minimum of 30 hours of Category 1 CME in that related procedure area in the past 3 years. And again, we have the 2 required CME for fluoroscopy radiation safety included. Nursing staff. Your nursing staff must be licensed registered nurse or a licensed practical vocational nurse. You must have a current BLS or ACLS. You must obtain a minimum of 30 contact hours, Category 1 CME in the related procedure area in the past 3 years. Again, back to your 2 radiation safeties. Each facility must have a qualified medical physicist appointed by the facility. The qualification pathways include board certification, or a second qualification pathway is past Part 2 of the ABR exam and completed CAMPEP approved residency in medical physics that includes diagnostic imaging, Or third, you can be licensed or certified in accordance with state and local regulations as a diagnostic physicist. So you don't have to meet all three of these pathways, you just have to meet one. Now, similar to the provisional staff member, if you are applying under number 2, you must reach full certification prior to the next accreditation cycle. So you can only use the number 2 qualification pathway for one cycle. The medical physicist must obtain at least 15 credit hours of CE approved by the Commission on Accreditation of Medical Physicist Education Program. A little bit about the emergency supplies and medications that are required. We have oxygen, AED. The ones noted here for epinephrine, analgesics, antihistamines with the VC, those are required for vein center accreditation. The rest of these are all for your new procedure areas that include local anesthetics, sedatives, saline, insulin, calcium chloride, dopamine, lidocaine. You see the list here. These are also listed in the standards. Additionally, we have beta blockers, succinylcholine, vasopressin, sodium bicarb also listed here, which is very important. One important thing is you must have a monthly inspection log of these medications. Make sure that, the secretary didn't come and take your aspirin because she had a headache. So make sure that you do have your inspection log near your emergency meds. Make sure they're clearly labeled for emergency use so we don't get the headache bandit again. And make sure they're secured with a plastic lock. If you have a combination on there, you have a key and it's floating around with the medical assistant, who's off to lunch and, we have an emergency, we want to be able to get into those emergency medications as soon as possible. But we also want to make sure that they're secure. Moderate sedation monitoring. If you are doing this in your facility, you are also required to have non-invasive blood pressure, pulse oximetry, epinephrine, and ECG monitoring. That leads us to our next poll question. Let's see if we can get this one rolling out a little bit easier than we were the last time. For the second poll question, what is the highest level of sedation you use for your vascular interventional procedures? Do you use mild, moderate, deep, or general? Let's see, do we have any results here? Yep, we certainly do. So it looks like, wow, 39% use mild sedation, 30% use moderate sedation, 28% use general sedation, and 2% use deep sedation. So a little bit about the documentation for your pre-treatment documentation, which is typically your clinical evaluation or any type of notes or worksheets or anything like that you have, pre-treatment. You must include the chief complaint, past medical history, family history, history of VTE if you're applying in deep vein, symptoms and treatment history, anticoagulation medication and treatment length, directed physical exam, SEEP and VCSS for deep vein, additional imaging, treatment plan, indications for your procedure, and lab studies. Additionally, you are required to have a consent form. You must have documentation of the name of the treating physician and patient, a list of allergies. If there are no drug allergies, you will have to document that as well. The Malapati score if you're using sedation, and an ASA score. You must also, intra-procedure, you must document and perform your timeout. If you're using moderate sedation, you must take vital signs at least every 10 minutes. That includes your blood pressure, pulse oximetry, pain scale assessment, level of consciousness, EKG, and respiratory rate. Your procedure documentation, which most of this is in your operative report. But, I also we understand that, people do keep worksheets and checklists and things like that. So as long as this is documented somewhere, in your medical record, you're fine. It doesn't necessarily have to be in your op note, but you must include the indication for the procedure, structures imaged, description of procedure, treatment success or inadequacy, operative findings, complications, sedation with monitoring provider, devices used, number of minutes of sedation and agents used, documentation of sterile prep and drape, all medications used, treated vessel, access site technique, access needle and sheath, patient status at the end of procedure, the name of the person performing the procedure, contrast type and volume, fluoroscopy exposure, estimated blood loss, and name of surgical assistant and or circulator. Patient instructions must also be documented, given to the patient. You will have to, produce them when we come out and take a look at your application. The patient instructions have to include procedure performed, management of pain, access site, dressings and wound care, anticoagulation or antiplatelet therapy, compression instructions, bathing and showering instructions, activity level or exercise, air and car restrictions, directions and contact info to access a healthcare team should there be question or an emergency, follow-up office visit instructions, and follow-up visits. Protocol and policy requirements. These are all listed in the standards as well, but we're just going to kind of go over them. You are required to have a policy or a protocol for the following, management of allergic reactions, infection control policy, treatment and or referral plan for patients with complications of the procedure, protocol for each procedure performed in the facility, incident report / adverse event policy, a patient pregnancy policy, patient pre-procedure preparation policy, and contrast medication administration and supervision policy. Protocol for patients requiring escalation of care, radiation dose evaluation policy, post-procedure follow-up policy, protocol for disposal of used or expired supplies, policies, protocols, and procedures regarding administration and supervision of intravascular contrast agents, patient customer complaint policy, primary source verification policy, confidentiality, protocol for sterilization, radiation safety, and record retention. And this brings us to our third poll question. I'm just trying to keep everybody awake out there. What programs are you interested in applying for? Peripheral arterial, deep venous, hemodialysis access, or more than one program? Okay, so we do have the results here. It looks like 54% are applying for more than one program. 16% are applying for peripheral arterial, 16% for hemodialysis, and 13% for deep vein. So it looks like it's pretty even across the board. So we're going to move into the application process, especially for those of you who are not familiar with the application process. The application process starts with a facility assessment. Basically, you go over the standards, see where your deficiencies are, see where some changes might need to be made. You're going to complete the online application. Once the application is submitted, we will come out for site visit. Once the site visit is done, the results of the site visit and any of the medical records, protocols, policies, that will all go to the board for review. And then that's when you'll be granted. So right now, the Vein Center is kind of a twofold program where you do a one-year grant and then we do site visit. Well, the new application process for these three procedure areas are a little bit different. You complete the application, which is mostly attestation, and then we come right out for site visit, and then you get your grant. So there's no more one-year grant. Also, I think I already saw a question in here. I'm pleased to announce that the application process should be easier now. We do have a multi-site application. This is for all. This is for all vascular interventional, the new and Vein Center. So this certainly should make things easier. For those of you who are accredited with us already, if you have any questions, please give us a call back to see if we can, figure that out for you. But we do have the multi-site application and also a multimodality application. So everything's all in one. If you want to apply for vein center, you can apply for just one. If you want to add 3 more procedure areas, you can do that too. And then you can add the rest of your 10 sites. So we are trying to make things easier. This is, new for us, and people have been asking for this for a very long time. So I'm super excited that we are finally able to offer this to our applicant facilities. The best place you can get your information, other than from us, which of course you're always welcome to call, is to check out the IAC website at intersocietal.org. This is where you'll access your account. You'll create your new account. There's helpful resources in there, information about reimbursement, news and events, value-added services, and legal information. Once you go on the website, you'll see the first thing is, your helpful resources. Under this tab, you'll be able to find sample documents, CE finders, on-demand webcasts. If you miss one of our webcasts or there's a special topics webcast, you can go on there and look at. You can learn how to market your accreditation. You can get help. We also have some information about COVID-19 and patient information. Second tab is reimbursement. It includes payment policies, CMS resources, how you can comply with MACRA, and how you can locate IAC accredited facilities. The news and events tab will include, upcoming webinars, when you can come meet us in person, when you check out our exhibit schedule to see where we're exhibiting at, and our newsroom. The value added services tab includes the QI tool, QI solutions, Center of Quality, system-wide accreditation, the IAC research program, the MOC activity, and international accreditation. Finally, under the legal tab, you can find information about the IAC agreement and the BAA, information about multiple sites, changes to staff, facility name, maybe you're keeping your accreditation, you're moving down the road, what do you do? All that information can be found here, as well as reporting a complaint, and the policies and procedures. So on the website, this is the homepage. This is where you will access that application. You'll either access your existing account if you're currently accredited in vein center or another modality in IAC. Everybody would be under the same account, so you can still, if you have an existing account, you would go there, even if you don't have a vascular interventional application. If you don't have any applications with the IAC, then you would create an account. I'm pleased to announce, I don't know if everyone got the notice, but for these 3 new accreditation areas, the arterial, hemodialysis, and deep vein, if you apply before March 31st, 2023, the applications for the first cycle, the first 3 years, are waived. So you will get that application for free. And the point is we really want to collect data. We are asking that in order to participate with these waived accreditation fees, we will ask you to participate with a survey. It's a short survey that you take prior to submitting your application. I think it takes 10 or 15 minutes. And then once we gather that details, you will have access to your application. And then once we're all through, we're gonna survey you again, because we want to see, what are the effects on accreditation? Does it improve quality? And can we identify any areas where we can improve? So, that's very exciting. If you can get your applications in before March 31st, you will have waived fees. And again, these are the new procedure areas. This does not include the existing vein center. When you access your application, or you go into there to create an account, you'll just put all your facility information in the tab. You will choose what testing modality you're interested in. Vascular interventional would be where you're going for. And again, everything goes under there, including vein center. In the application, you'll see this tree on the side, and this is where you'll enter your information for the procedure requirements. It'll have you attest to the volumes for your medical staff. You'll be attesting to CME. You'll be entering your equipment, all your staff information in here. your quality improvement, any fluoroscopy information about the medical physicist, all of that will be in here. And the good thing about this is it serves as a guide. Like I said, this is a little bit different than the Vein Center application. You're not going to upload any documentation at all. You are going to submit this application. You're going to test to say, hey, yes, I have these protocols. Yes, all my staff are compliant. These are provisional staff. And then, if you find areas where maybe you are deficient as you're going to the application process, then you can fix them. Say, okay, well, no, I can't attest to having this protocol. Let me write one up. So it really serves as a guide, and it's kind of a new way of looking at the application process to make it a little bit more streamlined. It will, at the end of the tree, it does say supporting documentation for your Vein Center. This is where you would submit documentation, but for the new application, it's just going to kind of tell you what we're looking at when we go to site visit. When we go to site visit, we're going to want to see procedure logs for all your staff. The logs must include the date of service, patient identifier, treating provider, and outcome. You must have the most recent annual physicist survey for each piece of fluoro equipment. The complication log, and the QI meeting minutes. A site visit is required for vascular interventional accreditation because that is pretty much the nuts and bolts of the application process. We're not going to surprise you. The site visit dates will be requested from you once the application is submitted. You should include dates that include observation of as many procedures as possible. So we will reach out to you, say, hey, we got your application, send us some good dates for us to come out. Again, no surprises. We don't want to show up on your, we don't want to show up your door when you're having a Christmas party or a holiday party. And then we'll tell you, say, okay, well, we've coordinated with the site visitor. We're going to come out on, January 13th between these times, and, you'll be able to, you'll know we're coming. The site visitor will observe patient procedures, including sterile setup, patient prep, the procedure, patient post-op care. They'll review patient medical records for the procedures at that time. Make sure you have that inspection log for your emergency supplies we talked about earlier, because they will be checking that. They'll make sure it has all the information. It's just not a list of the medications. You have to include the strength, quantity, lot number, expiration date, the staff member's name that performed the inspection, and the inspection date. Also, if you are performing autoclave on site, you must have a written protocol for sterilization of medical instruments. And you have to have logs. You have to have 2 logs. You have to have the results of the biologic monitoring and the sterilization records. Once we get to site visit, if everything is compliant, you will get that 3-year grant. Again, no more 1-year grant, not for the 3 new procedure areas. However, if you're not granted, you might have a delayed decision. This is a brand new program. We absolutely understand that the standards were just released last year. It's very difficult for you to, come up to compliance immediately. But that's kind of, that's what we want to do. We want to kind of raise the bar and improve healthcare. So, we kind of don't expect you to be 100% right off the bat. So if you're delayed, it just means that there's something you have to fix, and we will give you ample time to make those changes so that we can kind of work together and bring you up to speed. And we'll tell you exactly what was missing. This is an example of the letter that you'll get if, in fact, you are delayed. It'll say, now this is a Vein Center letter, I will say, because we don't really have much with the interventional yet, but it'll be very specific. It'll say, hey, your application's been delayed because this, that, or the other. And then below that, it'll say, in order to fix it, this is what you need to submit. And each bullet will correspond with, the rectification. So it's pretty easy to follow. Also, I want to remind everyone that you want to go into your application. There is something called your online application review findings. This is documented in that letter, that delay letter, and it does have a lot of information, and it will tell you how to get there. But unfortunately, what we see is a lot of people get the delay letter, they look at the problems, and their brain stops at that point. There's no more reading the letter. They miss this altogether. But there's some very valuable information in your application if you check your online application review findings. And this is located in your portal. This is just kind of a snapshot under the application tabs. If you click on this little, the icon that looks like a letter, you can look at the decision letter and the application review findings. And don't need to take notes on this. Once your decision comes out, we will send you an email that says, hey, this is how you access things. This is where you find your information. But it doesn't hurt for me to, kind of throw it out there because, like I said, people tend to panic and only read maybe a paragraph of the letter. This is an example of what the application review findings might say. It'll, show your strong points, and then it'll also say, okay, well, these are the things that you were deficient. So your letter will kind of, your delay letter will point you in the right direction. But if you need, more clarification, if you go to the application review findings, it will provide, more information. If in fact your application is delayed, you do submit your delay materials in your online portal. And you do this by selecting the applications tab and then uploading in the view delay materials icon. Again, this is also in the letter, but it doesn't hurt to show you. Just a little bit about common deficiencies we do see with the application process that you can avoid. Inconsistent infection control. We see contamination of sterile field all the time. So, review, re-review, do a little quality improvement, check your staff, do some in-services, I think people just kind of get in the, rigmarole of doing the same thing every day, and they don't realize that, hey, you're rubbing up against the sterile field, or, you one side's sterile, one side's not. I mean, we see a lot of this, unfortunately. So that might be something that you kind of want to look at the staff for and pay more close attention. Also, we see this a lot. The sterile table set up. We have 4 basins with solutions in them. We have 3 syringes and not a single label to be had. So be sure that anything that's pre-drawn in advance, make sure you have labels on those. Also, we go to site visit and Dr. Smith says, hi, nice to meet you. And we don't even know who Dr. Smith is. So just be sure that you include all staff in your application so there are no surprises at site visit. Another thing we see a lot are discordant findings in the chart. One part of the chart will say patient has swelling. The other part will say no swelling. Patient presents with ulcer, but their sleep scores are 2 and 1. So just, it doesn't hurt to go over your charts every once in a while. That is part of your quality improvement process. So you really should identify those deficiencies if you do truly are following the quality improvement process. And that leads us to quality improvement. Purpose of quality improvement is to evaluate your facility's current processes and implement a continuous improvement plan to maintain quality and safety for patient procedures. Your facility must have a written QI program to evaluate procedures on an ongoing basis. A minimum of 30 cases must be reviewed annually. So that's 15 cases per biannual QI meeting for the following metrics: procedure appropriateness, technical performance of the procedure, patient safety, medical record completeness and timeliness, and procedure outcomes. And we'll go over all of those. For procedure appropriateness, we're looking at, was the procedure appropriate, usually appropriate, maybe appropriate, rarely appropriate, or usually not appropriate. Technical performance of the procedure, you're going to want to review for completeness of the procedure, documentation of technical events, failure to perform the procedure, quality of the pre-procedure diagnostic testing, and adherence to facility protocols. For patient safety, you want to review completeness of the procedure, documentation of technical events, failure to perform the procedure, quality of the pre-procedure diagnostic testing, and adherence to facility protocols. I think we have a duplication there. For medical record completeness and timeliness, you want to evaluate time from the completion of the procedure to the signature of the final documentation. This must be completed within 2 business days. Finally, procedure outcomes. Your facility must have a written policy and process to track and document the outcomes of patients evaluated and treated. All outcomes in the medical record must be documented. All adverse events within 30 days post-procedure must be documented in a central location. So if there's complications and you just have it listed in the patient's medical record, it's not really good enough. You need to have a complication log. Reason being, if you can identify all those complications, you can, look for trends. See if there's something you need to change in order to improve your quality. Also, each case requiring referral outside of the center for treatment of complications must be reviewed. All adverse events within 30 days post-procedure. Also, for emergency medications and supplies, a monthly emergency medication inspection log must be documented and reviewed. I think that's the 3rd time I've said that, but that is certainly something that we do see that is a deficiency. So if you take anything out of this, I hope that you can take that. Routine inspection of medical supplies and equipment must be documented and reviewed. Okay, so you have all that. What do you do with it? Well, you have to talk about it. You have to talk about it and you have to document it. So you are required to keep QI meeting minutes. Each clinical staff must participate in at least 1 meeting per year. Your facility must have a minimum of 2 QI meetings per year, and they must include case reviews for the required measures, the ones I spoke of earlier: technical performance, final report completeness, patient safety, all those. You must review procedures resulting in an air kerma greater than 5 gray. You must review the monthly emergency inspection log. And you must have verification of routine inspection of medical supplies and equipment must be documented. So that's it for quality improvement. I guess that kind of wraps things up, but I just kind of want to see who's still awake out there. And if you can help me try to answer one of the most holidays burning questions. We do have one more poll question. Is Die Hard a holiday movie? And I'll wait for that poll. And I will certainly share my opinion once we get the poll results in on this. And if we don't have any poll results, I can see maybe I lost you. And it looks like I am outvoted. 71% say that Die Hard is not a holiday movie, while 28% say that they are. It is. Well, thanks for participating. I sure appreciate it. So if you have any questions about the standards, I understand based on the poll earlier, this is going to be a brand new process for a lot of people. So please, if you have any questions at all, feel free to give us a call. The Vascular Interventional team is here. I'm Laura Humphries. We also have Carrie Newell, the clinical specialist. Heidi Bernard is also a clinical specialist. So we are here to help. Send us an email, give us a call. We even have a fast path chat in the application. If you're filling out the application and you can't figure anything out and you want immediate information, send us a chat. If we're working, if it's during normal business hours, we will certainly respond. And that is all I have for today. And I certainly appreciate everyone for attending and participating in all my polls.
Okay, thank you, Laura. And at this time, we will begin the Q&A session. I'd like to introduce Marge Hutchison, our Director of Accreditation for Vascular Testing, assisting with the Q&A session today. Marge, would you like to start us off?
Thank you, Kelly. Thank you, Laura. That was an excellent presentation with a lot of new information. The first question is regarding medical physicists. This facility, their C-arms are certified by a physicist from the county. They don't really appear to employ one. So is that Okay.
You can have a physicist as a contract employee if that's what you're referring to. I mean, of course, they will have to perform, as long as they perform the duties required in the standards, that's fine. As long as they're doing that, they don't necessarily have to be employed in your facility. They just have to be appointed by the facility.
Okay, great. The next question is, do all the case volume requirements apply to each operator for deep venous and peripheral arterial?
That's a great question. So if you remember back in the slides, yes, the case volumes are per operator. So it was, generally 20 cases. We'll just throw that out there. I know they're all a little bit different. If the standards say 20 cases are required over the past 3 years, that is per operator, per provider. Like I said before, there are only a couple that are absolutely required. The other procedures are listed in the standards with case numbers, but they also include documentation if performed. So if you don't perform them, you don't have to have those case volumes. But it's also okay if Dr. Smith does perform angioplasty, but Dr. Henson applies in venous stenting. They don't all have to perform the same procedures unless it's those 2-starred. They can be all over the board, but those are per operator, per provider.
Okay, and a question that kind of goes along with that one. Can the case volumes come from a different facility?
Yes, absolutely. That's a little bit different than the vein center. The vein center has facility volumes. These new procedure areas do not. So these training and experience pathways for these medical staff are case volumes done anywhere. So yes, especially if you're at a new center, you don't have to wait 3 years to get them. If you've performed them down the street over the past 3 years, that's fine.
All right. This person is asking about staffing. They employ RVTs in their cath lab and want to know, it doesn't appear as though you have RVT standards.
No, we don't have any standards for the sonographer per se. Usually, I mean, for the vein center, the sonographer plays a pretty big role in the procedures. As far as, the interventional, not quite as much. So we do not have any standards for the sonographer.
All right. Let's see. This person is asking for your recommendation on applying for it appears to be deep vein accreditation. If they're just now building their center, what should they apply now, or should they wait, or what should they start doing?
If they're just building, I guess this is kind of a hard question. I mean, if you're currently employed in a center and you're moving to a new build, then I would say certainly go ahead and apply. And you can certainly transfer the address to your new center. If you're just creating a new center or building a new center next year and you don't have policies, procedures, equipment, staff, any of that yet, I would probably say hold off. Don't apply until next year, but for right now, you can get all the legwork done. I would certainly still start the application. Like I said, the application is used as a guide. It'll show you where you're deficient. So I would start the application and do some homework using that kind of as a study guide until you're ready to apply. If you start, there's no fee to start the application at all, and it doesn't expire. So that's what if you are just, thinking about starting a place from the ground up next year, that's probably what I would recommend.
All right, thank you. Is IVUS a must for deep vein and peripheral arterials?
Oh boy, that's a trick question. It's a must for one and not a must for the other. Hold on for just a second. Yes, IVUS is a must for arterial. No, okay. I'm sorry. IVUS, I take that back. IVUS, you must perform IVUS and angiography for deep veins. For peripheral arterial, it's angio or IVUS. So for arterial, not necessarily. For deep vein, yes.
Okay, that makes sense. Do provisional medical staff need CME?
Absolutely. Yeah, the point of the provisional staff is only to obtain your volumes. Everything else, you must also have your CME, you have to have your ACLS, you have to have all that stuff. The only thing provisional does is help you, get your volume so you can be a full medical staff member.
Okay, and in regards to CME, do they need it for all the areas they're applying in, or can they just be general interventional CME?
No, you need the CME specific to whatever area you're applying in. So if you're applying for deep vein, the CME have to be related to deep vein.
All right. Do you need ACLS for mild or moderate sedation?
ACLS is required for moderate sedation. I believe that's only for nursing staff. I believe that I think it has to be ACLS, and I apologize. This is again a new program I stated in the beginning. So let's see here. CME, well, not CME, provisional medical staff. I do believe it's ACLS. ACLS, yes, it's ACLS no matter what for medical staff.
Okay. And you mentioned that the APP must perform 50 patients. Is that referring to H&P?
Yes. We're not referring to performing the procedures. Those are if the APPs are forming the treatment plan, they're doing the consults. If they're doing that, then they would be included in the application and they would have to meet that minimum case requirement.
All right. You talked a little bit about dialysis access and removal placement. Can that be done outside the OR?
Well, I mean, if it's done on a ambulatory surgery center, I think that's, where we see it. Certainly wouldn't want that being done in an office. But yeah, I mean, the majority of these, the purpose of the interventional, while these can be performed in the hospital OR, it's kind of more so targeted towards our OBLs and our ASCs. But yes, I mean, some of the procedures listed in here probably can be done in the ASC, but not all. It all depends. It really just depends on your state regulations. So I really can't say for sure.
Okay. And with 2 minutes remaining, this could be the last question. Regarding anesthesiologists, there's no standards for them in the standards. So if we do ours under general anesthesia, do they just kind of let the anesthesiologist go?
Well, I mean, we don't let the anesthesiologists go. They don't have to be included in the application. We don't have standards for the anesthesiologist, but we will ask for additional documentation to make sure if the patient's under general sedation that everything is being monitored appropriately. So they don't necessarily get let go. We will look at that, but they aren't included in the standards.
All right. Well, thank you, Laura. With 1 minute remaining, I'm going to turn it over to Kelly to close out the session.
Okay, great. Thank you, Laura and Marge. And thanks again, everyone. Please feel free to contact IAC with any questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. The link to the survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. On the left side of the My Account page, you'll click on Webinars. Look for the title of this session, Introduction to Vascular Interventional Accreditation. Beneath this title, you will click Review Event. On the left, select the Evaluations tab, then click Take Evaluation to complete the survey. Your certificate can then be accessed and printed from the very next screen and anytime thereafter through the CE transcript section on the My Account page. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you for joining us today and appreciate your participation.